So let's make sure we are all, let's make sure we all muted so we can have a beautiful experience to Jenny.
Okay, can you guys hear me? Good, okay. So we first want to introduce you all to Jim, who is pictured here with his greatest treasure in life, his best friend and his wife of 49 years, Mary. He and Mary built a wonderful life together. They raised 2 beautiful children. Jim dedicated his career to teaching high school biology. Jim retired last year, and he and Mary were looking forward to slowing down, having more time with their 3 grandkids, and checking some travel destinations off their checklist. But 3 months after Jim retired, he learned that the fatigue he'd been having the last few months of teaching was more than just his increasing age. He was given the diagnosis of a highly aggressive lymphoma, a type of blood. He spent the next 3 months, including he and Mary's 50th wedding anniversary, undergoing intense chemotherapy to try to cure his disease. Despite this, Jim remained optimistic. He came in for his 6th and final course of chemotherapy. He had overall tolerated his therapy pretty well, and his doctors were pleased and reminded him of the very likelihood that he would be cured of his cancer. He and Mary chatted about their upcoming trip to visit their wife or their kids and their grandkids while the nurses hung the chemotherapy and connected it to his central line, the device that delivered this life-saving chemotherapy to his body. 4 days later, Jim spiked a fever. He had never had any problems with the chemotherapy, but this time he felt exhausted. The care team moved, checking labs, running tests, trying to figure out what was going on. That night, Jim's blood pressure continued to drop despite all of these interventions. He was moved to the ICU. The team called Mary for updates and to get consent because Jim quickly became unable to communicate on his own. His kids flew in to support Mary. 3 days later, it became apparent that Jim was not going to recover. The care team met with Mary and their kids and explained how an infection had originated from his central line and spread throughout his body. An overwhelming infection that had caused his organs to fail. There was nothing left they could do.
I wish there could be something we can do, if not to prevent cancer, to prevent infections.
Unfortunately, Jim's case is not an isolated case. Central line associated infections affect 80,000 patients a year in the US and cost hundreds of millions of dollars to treat.
You know, I've been reading and there's already bundles that are available that have been proven to reduce central line infections.
Bundles? And why don't we use them?
Well, that's a good question. It does take an average of 17 years to bring scientific research findings into clinical practice.
That sounds very interesting, but I just don't see how we can do more with the number of patients that we have.
Well, you bring up a really good point. Creating change is definitely not easy, especially when our daily tasks are so overwhelming.
And we have so many different providers placing central lines that sometimes it feels as if it is our fault, the nurses, that the lines are getting infected.
Oh, but this issue is not just due to the failure of just one team. It's because we don't have the right tools, processes, or strategies in place to be able to correct the problem. We need to ensure that people are involved at every level, from administration to physicians to nurses and patients, and that they are engaged and willing to devote time and resources to solve this wicked problem.
Well, hospital leadership is ready to make central line associated blood infections our priority and to provide resources to reduce expenses related to these infections.
This is a great starting point. If there's demand at the administrative level, it will allow us to secure the resources that we need. We'll first need to clarify our goal and then work to ensure there's demand at all provider levels.
Well, I think that sharing stories like Jim really touches the nurses' values. We don't want to cause harm, and we spend all our time and energy trying to improve people's lives. Doing something that saves lives would make our life and our work more meaningful.
It is important to understand the workflow of everyone involved. We do need to understand their workloads, their beliefs, their motivations, and their frustrations. And the solution needs to come from every team that is involved in the placement and care of central lines, including the patients and their families.
Well, I've spoken with nurses from different units. They all had sad stories to share. They don't know what to do different. There's no standard process.
And I've met with the department chiefs of all services that place lines. Everyone is struggling on how to reduce infections. They have many learners in their teams. They think that training might help.
Same for nurses. They would welcome training.
We can use evidence-based processes and strategies that already exist and adapt them to fit our own environment.
This is exciting. We mapped different processes for each team, the physicians placing central lines and the nurses caring for those.
And we've met a few weeks ago with the central line kit supply manager. He explained that there are 7 different kits available for central line placement. I would imagine using a kit you're not familiar with increases the risk of a central line infection.
That's interesting and provides valuable information. Our goal is to standardize this process using the information that we've gathered.
Our next step is to engage physicians, nurses, and surgical techs to create one kit that works for everyone.
Well, I'm sure that the idea of designing our own kit is very engaging for everyone.
Okay, we've met with our multidisciplinary team, including infection preventionists, physicians, and pharmacists, to integrate the practice guidelines that already exist of central lines in our hospital, indications for central lines, duration of how long they should be in, and removal indications.
Great. On our side, we met with the nurses team leads about implementing daily chlorhexidine bathing, appropriate dressing, tubbing changes, and skincare. And we created our own bundle checklist.
Then it sounds like our next step would be to design a training in order to increase bundle adherence, sterile technique, hand hygiene, and central line infections or central line maintenance. We should design this training as a collaborative effort, including all professions and disciplines involved.
Wow, this is a great start. I just worry that simply having the information might not be enough.
Well, you're right. And to address this, we need to engage leaders at all multiple levels in the hospital and raise awareness about the program to motivate buy-in. We need to appeal to the hearts and minds of all those involved in order to increase demand for this training without making it mandatory. I think that the best way to do this is to have the right messenger using storytelling.
We need to tell Jim's story and the stories of so many other patients like him.
I think it would work best if a nurse who attends the training tells others. Like after I attended, I can tell other nurses how great it was.
Tell me how things are going.
Yes, well, we just attended our bi-weekly meeting on the recent CLABSI events and reviewed our scoreboards to identify what went well, what didn't go well, and what we plan to do differently.
It also looks like we successfully changed behaviors that reduced not only CLABSIs, but other hospital-acquired infections as well.
It's too bad we didn't have those processes in place when Jim was here. Just imagine how many families that we've been able to help and make these precious memories because of the lives that we saved, reducing central line infections.
So as we wrap up our case tonight, and perhaps as you guys all forgive our, or at least my, lack of acting skills, we think that it's important to emphasize that the solutions that were used for this particular problem were not created and were not new, but success of this program was solely the implementation of guidelines that already existed using modifications that were specific for this environment. And it was changes in these processes that led to sustained success for the entire system. Thanks.
Wow.